Hemolytic Uremic Syndrome by Sara S
and Jenna R.
Objective is to describe the pathophysiology, clinical manifestations, diagnostic evaluation, therapeutic management, and nursing considerations of a child with hemolytic uremic syndrome. Target population and etiology. It targets infants and small children between the ages of 6 months and 5 years. Frequent cause of acquired acute renal failure. It's associated with bacterial toxins, chemicals, and viruses. Usually follows a GI or respiratory infection. Causes are endotoxin, Shigella, E. coli, and Salmonella. E. coli infections have been traced back to undercooked meats, especially ground beef. Other sources include unpasteurized milk or fruit juice, especially apple, alfalfa sprouts, lettuce, and salami. Drinking or swimming in sewage-contaminated water is another source of infection. Occurs in infants and children who have not developed antibodies to the Shiga toxins. Pathophysiology. Endothelial lining of the small glomerular arterioles are damaged, which become swollen and occlude with deposits of platelets and fibrin clots. Red blood cells are damaged when they move through the partially occluded vessels. Damaged cells removed by the spleen lead to acute hemolytic anemia. Platelet aggregation and removal of platelets leads to thrombocytopenia. Diagnosis. There's a triad of anemia, thrombocytopenia, and renal failure. Renal involvement is evidenced by proteinuria, hematuria, urinary casts, elevated BUN and creatinine, low hemoglobin, hematocrit, and high reticulocyte, PTT and PT, increased white blood cells, and bloody diarrhea.
Early clinical manifestations include vomiting, diarrhea, irritability, lethargy, weakness, blood in stools. Late clinical manifestations include decreased consciousness, marked pallor, hemorrhagic manifestations, which include bruising, petechiae, jaundice, and bloody diarrhea, olguria and anuria, and CNS involvement, which includes seizures and coma. Goals and prognosis. The goals include early diagnosis and aggressive supportive care of acute renal failure and hemolytic anemia. Prognosis. Recovery rate is 95% with prompt treatment, but residual renal impairment is anywhere from 10 to 50%. Complications include chronic renal failure, hypertension, and CNS disorders. Management includes hemodialysis or peritoneal dialysis. Hemodialysis or peritoneal dialysis is instituted in any child who has been anuric for 24 hours or who demonstrates oliguria with uremia or hypertension and seizures. IV fluids, fresh frozen plasma, plasmapheresis, monitor INO, vital signs, electrolytes. Skin care, avoid nephrotoxic drugs such as NSAIDs, and include a high cal, high carb, no added salt diet with low potassium. Limiting fluid intake in younger children requires creativity on part of caregivers to cope with the child who is thirsty. Rationing the daily intake in small amounts of fluid served in containers that give the impression of larger volumes. The nurse must be alert for behaviors that indicate the new onset of complications. Infection is always a constant threat. Fluid and electrolyte disturbances can precipitate cardiovascular complications such as hypertension and cardiac failure. More management includes being a supportive, empathetic nurse, which can provide comfort and stability in a threatening and unnatural environment, provide reassurance to parents, and keep them informed, and explain the child's therapeutic regimen.